I apologize for being late today, and this was a talk I was supposed to give yesterday, and Schweitzer, I believe, gave his talk, and I thank him as well. And our local host, Dr. Awad, that I communicated with before, I also would like to thank him for his help organizing this meeting. So my first talk is on plain film evaluation of bone tumors. As you know, although more advanced imaging modalities between widespread bone tumors are still best evaluated with radiographs, and I would like to talk about that in the next 45 minutes or so. So when we see a lesion, there are a number of things we look at immediately, including patient's age, location of the lesion, whether the lesion is solitary or multiple. That will also change our differential, and history and symptoms if they are available. Most of our cases, unfortunately, we don't get very good history, with the exception of referrals from orthopedic oncologists. The majority of the bone tumors are going to be in the metaphyseal area. When we go into the epiphysis, the differential is going to be shorter with chondroblastoma and giant cell tumor in the later age. Then when we look at the diaphysis, we're going to have the round cell lesions like lymphoma and Ewing cell tumors. And fibrous dysplasia can also be seen in that area. So when we look at an individual lesion, the first thing we should look at is the margins, and we should also look at the presence or absence of periosseous reaction, cortex, and matrix if there is any. When we look at the margins of the lesion, we always talk about geographic, well-defined lesions. This usually indicates a slow-growing process, and sclerotic is the slowest growth, and well-defined non-sclerotic is, again, slow growth, maybe not as slow as the sclerotic margins. And you can also see some ill-defined margins in this group. When we have the sclerotic borders with geographic margins, we have the typical example of simple bone cyst. You can also see that with chronic infections like Brodie's abscess, benign fibrous tumors, fibrous dysplasia, and non-spinal fibromas as well. Here's an example. There's a lesion with well-defined geographic margins in the proximal humerus with sclerotic margins. And in this patient who was 19, this was a chondroblastoma. It's involving the epiphysis and the apophysis, the metaphysis and the proximal humerus. When we look at lesions that are well-defined margins without sclerosis, giant cell tumor is the typical example, but we can also see that with cartilaginous tumors like enchondroma and in some cases of chondrosarcoma as well. And fibrous dysplasia may also have non-sclerotic, well-defined margins, and so are some cases of myeloma and metastatic disease as well. This is the example of giant cell tumor. It's involving the end of the bone, again, has pretty well-defined margins without much sclerosis around them. And the ill-defined margins, again, are more difficult to tell compared to the first two groups, but we have the chondrosarcoma and chondroma, and also in some cases of e.g. giant cell and osteosarcoma as well. Here's a lesion that's located in proximal tibia. It has pretty well defined margins without sclerosis, and the MR shows the extent of the lesion. This turned out to be a metastatic disease. And this is a patient with plasmacytoma. Again, it's pretty well-defined margins in the proximal femur in this elderly patient. This was plasmacytoma. This is a case of metastatic disease. The lesion is hidden back there. It's much easier to see that on the CT examination with destruction of the medial will stem. The moth-eaten type of margins indicate indicates a faster growth compared to the geographic, and we can see that with osteosarcoma, round cell tumors like Ewing's and lymphoma, and also non-neoplastic conditions like osteomyelitis may also have that. Here's a case of an osteomyelitis in this youngster. The growth plates are open, and you can see less well-defined margins, and you also see the overlying periostitis in this patient. This was chronic osteo. The last type, that's the most aggressive. We always use it as a buzzword. When we say permeative, it's almost never good. And typical examples are going to be Ewing sarcoma, osteosarcoma, and the rest of the round cell tumors like lymphoma and osteomyelitis, especially in the acute phase if it's destructive. Here's a patient with Ewing sarcoma. You can appreciate how permeative it is, that it's very difficult to see where the lesion starts and stops in this patient. Here's an older patient, 56-year-old with total arthroplasty and the leg pain. You can appreciate that there are some ill-defined lucencies in this tibial shaft. When an MR was done, you can see that it was just the tip of the iceberg, and there's a large infiltrative lesion of the tibial shaft with soft tissue extension. This is quite typical of lymphoma. The age group is typical, as well as the permeative involvement on radiograph and soft tissue mass on MRI. Another thing we look at is the periosteal reaction. If there is a solid periosteal reaction that indicates a slower growth, that body is able to react to the lesion. Here's an example of a solid periostitis in proximal tibula. You can see how thickened the periosteum is, how smooth the margins are. And that's actually a lesion, the chondroblastoma in the proximal tibula. When there is layering and onion skinning, that usually means that it's a faster growth in the lesion. Here's an example of faster growth, and you can appreciate the individual layers, although it wasn't reflected that well here. So it's a more aggressive process we're dealing with here. I think one of the most aggressive types is the sunburst or heron, and as you can see here, and this is a patient with osteosarcoma. You can see the spicules coming out of distal femur posteriorly, and this is an older patient with prostate met, which is an unusual appearance, but I've seen it in a few patients where you can see a very aggressive periosteal reaction around this prostate met with the heron and type of periostitis. It's unusual to see Hakan's triangle, but it usually means that a very aggressive process is underlying this periostitis, and there's interruption of that quick periosteal bone formation, creating this angulated appearance. Here's an example of a patient with Ewing sarcoma and very ill-defined margins of the lesion, and you can see that it's interrupted in this area, creating this Hakan's triangle appearance. And in some patients, you can see a combination of all these, one, two, or maybe more, all in the same area. Overlying cortex usually is expanded if a change in benign lesions. If there's expansion, we always consider that as a good sign, meaning that the lesion has been there for a long time, gave the body a chance to remodel around this area. Here's a good example of that in this patient with non-spine fibroma. You can see that there's an eccentric lesion with well-defined sporadic margins and expansion or remodeling of the overlying cortex. Here's another example where we see remodeling of the cortex in this patient with a healed unicameral bone cyst. So when we see the cortex cortex destroyed, we always consider something aggressive. In this patient, you can see that essentially there's no cortex left in the proximal humerus medially with soft tissue extension. This was affected with renal cell carcinoma metastasis. Next on the list is the matrix mineralization. When we look at a radiograph and we see a lesion, we look to see whether there is any matrix within the lesion. The matrix can be cartilaginous, fibroosseous, osseous, or dystrophic in some cases. Here's a typical example of a cartilaginous rings and arcs type matrix, quite typical of an chondroma, which is an instantal finding on this knee radiograph. Here's another chondroid lesion. Again, it's an arcs type calcification, but when you look carefully on this patient, you also see some periostitis and abnormalities in the adjacent soft tissues. This is a patient with chondrosarcoma. That's one of the things we use when we're dealing with a chondroid tumor to look whether this lesion is doing anything outside the bone. Anything that's happening outside the bone is suspicious for a chondrosarcoma and a large chondroid lesion, with the exception of fractures. Fractures can occur through chondromas and may appear as abnormalities reaching the surface or outside the bone. And this is an example of osteoid matrix. Compared to chondroid, this is much denser. It's almost cloud-like. In this patient with parossial osteosarcoma, you can appreciate the density and the uniformity of the periostitis in this patient. In addition to that, we also see this lucency that's going underneath this tumor, between the tumor and the underlying bone. This is a cleavage sign we typically see with parossial osteosarcomas, and the idea behind this is the parossial osteosarcomas probably arising from the outer layer of the periosteum, giving this cleavage sign on the radiographs, which is quite helpful when you see it. Fibroosseous matrix is less common than the first two, and the typical examples are going to be fibrous dysplasia and some healed NOFs or healing NOFs. There's a case where it's almost ground glass-like matrix in the proximal humerus. This is quite benign looking, and it's a patient with fibrous dysplasia. The last group in the matrix is the dystrophic one. It's very difficult to see on this radiograph, but there's a little calcification associated with that lytic lesion. And look at the CT on these axial images, you can see that there is a cluster of calcification. So this was more of a dystrophic calcification on this patient. This is an aggressive-looking lesion in the retrochanteric femur. And when we look at these lesions, if you see multiple, then we think about metastatic disease or myeloma. But you can also see benign lesions that are multiple, that are usually quite typical of the solitary lesion, whatever they may be, whether it's osteochondromas or Olney's disease. You also see multiple lesions with EG, vascular lesions, and non-neoplastic conditions like hyperparathyroidism. Some metabolic bone disease may also present with multiple lesions. Here's an example of a patient coming in with hand pain. As you can see, there are several lesions. There's one here, and more distally destroying the cortex, right around here. Elsewhere in the body, you can see it in the skull and long bones, when you see this type of permeative lesions with cortical destructions. We would be thinking about metastatic disease or myeloma. And both of those conditions are very rare in the distal extremities. When you see an appearance like this in the distal extremity, one thing to consider is a malignant vascular lesion. And this turned out to be a malignant vascular lesion, hemangiopericytoma. This is a youngster with multiple lesions in the right upper extremity, and some of these lesions look like involving the surface, and some of them more central. It's a patient with Olliier's disease. When you're dealing with Olliier's disease, the lesions you see are going to be different than solitary chondromas, and some of them are periosseous chondromas, and some of them look pretty aggressive, and can individually those lesions would look almost malignant, but in the context of Olliier's disease, it's quite normal. The progression of the lesion is probably the most important thing for those patients to consider malignancy. Another patient here with multiple chondromas. A patient had resection of distal ulna for possibility of ligament transformation. The patient also has these little calcifications. Here you can see some platelets. That's where this is a patient with Macucci's. We have multiple chondromas and hemangioma, the same patient. First saw this case, I was just looking at one big long lesion. And then if you look a little more carefully, there's also a lesion on the pelvis, so this is a patient with multiple fibrous dysplasia lesions. There's another patient with sessile osteochondroma, so this is a patient with multiple osteochondromatosis or hereditary multiple exostoses. I'm done. I guess I went a little faster than I should. Any questions?
Again, do you think that plain X-ray, when we are dealing with bone tumors, can we depend only in some cases on plain X-ray only, or you have to do all the workup starting from plain to scan, CT, MRI?
I think there are a number of cases there we can confidently diagnose on radiographs and start right there. Things like chondromas, fibrous dysplasias, nanospine fibromas. These are very commonly seen on radiographs, and they don't require additional imaging unless there is a complicating factor, whether there's a pathologic fracture or some other reason that would require us to do additional imaging. But for those lesions, if you're pretty confident looking at the radiograph and it's benign, I think I would stop there. If further imaging is required, MR is more often obtained, but most of the time, hoping that we can see the extent of the lesion, it doesn't really help us very much with the diagnosis, with the exception of certain things like maybe osteoasteromas or aneurysmal bone cysts, where we can actually see features that help us to diagnose those entities. And compared to MR, CT is less frequently obtained when you need another imaging modality. And CT is very helpful to evaluate the integrity of the overlying cortex or detecting subtle matrix mineralization, which might be difficult in some cases on radiographs. But in general, bone tumors are still diagnosed with radiographs without the requirement of an MR or CT.